Hi guys, as I have discussed earlier about the overview of the clinical anatomy of the brachioplexus. So we now discuss in detail about individual aspect. First is a long thoracic nerve injury causes paralysis of serratus anterior that causes winging of scapula. So we will study about this in detail. You can see here, this is the winging of scapula. See, you can appreciate this. You can see, visualize this. This is it's like a wing, right? Elevated, scapula is elevated due to it's due to the paralysis of serratus anterior muscle. Here it will be right, serratus anterior serrations, zigzag muscle, right? So paralysis of that serratus anterior muscle cause elevation. You can see clearly here. See, this is the long thoracic nerve. Long thoracic nerve. It's got injured. See, this is the serratus anterior muscle. It's got paralyzed. That means it won't pull this scapula. Like it doesn't act on it. So that's why this scapula will be raised, because this rhomboid muscle will pull this. It will elevate, so causing elevation of the shoulder blade. That is scapula, winging of scapula. You can clearly appreciate here the long thoracic nerve injury cause winging of scapula. Same you can see here. This is Nettus atlas. See, long thoracic nerve damage. Serratus anterior muscle helps stabilize scapula. It helps to stabilize the scapula. But if the long thoracic nerve get injured, this serratus anterior muscle get paralyzed, which can't stabilize the scapula. So the winging of scapula is, we can see, the lesion of long thoracic nerve causes weakness of the serratus anterior muscle with winging of scapula. See, winging of scapula most pronounced when pushing against stationary object with arms in forward elevation. Like this is a kind of test. Go to near a wall and put your two hands on that wall, and you start pushing it. Like pushing a stationary object. Wall is a stationary object, right? When you try to push the wall, like you can clearly see the scapula which is being pulled up, causing being like appearance. See, this is the normal scapula, but when you push, it's like winging. It's elevated. Forward elevation of arms with push against stationary object. Same theory. So we have completed long thoracic nerve injury. So we'll move on to suprascapular nerve entrapment. Here you can see this is the suprascapular nerve entrapment. See, this is the suprascapular nerve which is inflamed as shown here, or it is injured. See, it goes like this, right? So see, it's got entrapped, stuck, or what we can say is it's compressed in between these two structures in this gap or a tunnel like thing, which causes its inflammation or injury or compression, causing these supraspinatus muscle and infraspinatus muscle paralysis. You can clearly see here. See, this is the suprascapular nerve which is going to this through this notch, this suprascapular notch. See, this is the superior transverse scapular ligament. So here is a notch, superior scapular notch. From this it will go to reach these muscles, infraspinatus muscle and the supraspinatus muscle. It innervates. If injury to this suprascapular nerve causes the paralysis of supraspinatus muscle and infraspinatus muscle, which you can clearly see here, like these depressions, because the muscle is atrophed, will eventually atrophy. So wasting of the muscle, right? You can clearly see here supraspinatus muscle wasting. See, this muscle wasting you can see clearly. This is the normal one, this is injured one. Infraspinatus muscle wasting. See, you can see clearly. So muscle wasting is seen. See, this will clearly defines this wasting. See, this is infraspinatus muscle, supraspinatus muscle. So this is the suprascapular nerve entombment. Suprascapular nerve entombment. So guys, now we'll see this Erb's palsy and Klumpke's paralysis. This is Klumpke's paralysis. This is very much important. We will study it in a comparative way. So this is the full distribution of the brachial plexus. We'll discuss at last. So important lesions of the brachial plexus. Very important topic in this clinical anatomy of the brachial plexus. So Erb's palsy, Klumpke's palsy, also called as paralysis. It is the upper plex injury. It is the lower plex injury. Erb's paralysis is the upper plex injury. Klumpke's paralysis is the lower plex injury. The site of injury, upper trunk of brachial plexus. So that's why it's called upper plex injury. Here, in Klumpke's paralysis, the site of injury is lower trunk of the brachial plexus. That is lower plex injury. See, there is a classical point like Erb's point where 6 nerves meeting point. That is called Erb's point. As you can see here, this is the Erb's point. See, from C5, C6 root, it unite and form this Erb's point where you can see the suprascapular nerve and the nerve to subclavius and anterior division, posterior division. See 1, 2, 3, 4, 5, 6. You can visualize like that. So 1, 2, 3, 4, 5, 6. 6 nerve meeting point, right? This is the Erb's point. Injury to this Erb's point is nothing but Erb's paralysis. Okay. The cause of injury: fall on the shoulder, outstretched hand. Fall on the shoulder, direct trauma, outstretched hand can cause injury to this Erb's point. And second one is the birth injury, difficult childbirth. During pastration, during birth, and there can be injury to this brachial plexus, causing Erb's paralysis. And third, during anesthesia. During anesthesia, brachial plexus block. What we can say is, this is the procedure. Brachial plexus block. When doing a surgery to the upper limb in orthopedics or any department surgery. So during operations, the brachial plexus is being blocked by the anesthesia. So if you pierce the needle in such a way that you damage the brachial plexus, it causes injury to the Erb's point, which leads to the Erb's palsy. We'll study it in anesthesia. See here, the cause of injury is hyperabduction of the arm. Hyperabduction. Sudden upward pull of the arm, that is nothing but abduction. Hyperabduction of the arm in sudden way. So it causes the injury. Second is the arm pull into the machinery. And during birth injury, as of this is also during birth injury. Extended arm in breech presentation. See, in breech presentation, it can be happened. Extended arm in breech presentation. We'll discuss what is this breech presentation, causing Klumpke's paralysis. So the nerve roots involved are mainly C5 and C6, as we have discussed here. C5 and C6. The nerve roots involved here is C7, C8, T1R mainly. Sometimes C7 can also be there. Okay. The muscles paralyzed. So the biceps brachii, deltoid, brachialis, brachioradialis. These are the main muscles that are paralyzed. The partly are supraspinatus, infraspinatus, and superior muscles are also paralyzed. The muscles paralyzed in the Klumpke's paralysis: the intrinsic muscles of the hand and the ulnar flexors of the wrist and fingers. This you need to remember. There can be MCQ on this. See. Now moving on to the next one, the deformity. The deformity in the Erb's palsy is policeman's tip hand. Like police acts tip by keeping their hand backwards. Same, the waiters tip hand. Waiters also ask tip like this. They keep their hand besides and backward and ask for the tip without letting others know. And porter's tip hand, it's also called. So these are the synonyms of this deformity. See, arm hangs by side, adducted, medially rotated. It's adducted. See, it's adducted and medially rotated. See, medially rotated. See, the arm is adducted, and it's medially rotated. See, it's medially rotated. Forearm extended. The forearm is extended and pronated. You can see the forearm, sorry, you can see the forearm is extended, it's extended and pronated. It's pronated, it's twisted like this. So this is the deformity appearance. See here, it's a drooping of eyelids, ptosis. Horner syndrome can also be there. The damage to C5 and C6 nerve root. Forward rotated shoulder, upper arm redness, muscle atrophy and diminished arm length, weight as deformity. This is the deformity of the Erb's palsy. And here the deformity in Klumpke's palsy is claw hand. Unopposed action, long flexor and extensions, unopposed action causing claw hand, claw-like. In claw hand, metacarpophalangeal joints hyperextension extended, interphalangeal joints flexion, then flex, and the metacarpophalangeal joint hyperextension. It's like claw. I will show you. See, this is the claw. See, interphalangeal joint flexion. See, flexed. Metacarpophalangeal joint hyperextension. See, metacarpal phalanx hyperextension. That is the claw hand. And the disability. The following movements are lost. As I discussed, the muscles that are involved. So these muscles are paralyzed, right? So which causes disability of that movements. The following movements are lost. Abduction, lateral rotation of shoulder at the shoulder joint, of arm at the shoulder joint is lost. Flexion and supination at the arm. These movements are also lost. Flexion is lost and supination is lost because supinator muscle involved, right? See, supinator. Biceps, jerk, biceps and supinator are lost. No reflex, biceps tendon reflex. Lower part of a deltoid, sensations lost. So this is the disability. Deformity, disability. You should know about this. And coming to Klumpke's paralysis, disability, complete claw hand, cutaneous anesthesia and analgesia in a narrow zone along ulnar border of forearm and hand. So no sensations are felt. And if you come to the clinical presentation of Erb's palsy, you can see here, see, this is the deformity, beta strip deformity, polystrip deformity, Potter's deformity. See, the paralysis, the muscles which are paralyzed are biceps brachii, deltoid, brachialis, brachioradialis, and supraspinatus, backside supraspinatus, infraspinatus, supinator. So the biceps brachii paralysis cause extension of the elbow, pronation of forearm, and deltoid paralysis cause adduction of the arm. See, it is adducted, right? Close to the trunk. So adduction of the arm, extension of the elbow, pronation of the forearm, and supraspinatus, infraspinatus, medial rotation of the arm. See, medial rotation of the arm, medially rotated, it's rotated. So Erb's palsy, Horner syndrome symptoms can also be there. See, ptosis, drooping of eyelids, that is ptosis is also there. Upper arm redness, muscle atrophy and diminished arm length, bird swinging scapula, damage at C5 and C6 nerve root, beta stick deformity, forward rotated shoulder. These are the clinical features of the Erb's palsy. When it comes to Klumpke's paralysis, claw hand, loss of sensation along the medial border of the forearm and hand. Horner syndrome, T1 is injured proximal to white ramus communicans to first sympathetic ganglion. That is the feature of the Horner syndrome. The injury at T1 proximal to white ramus communicans to the first sympathetic ganglion, which causes ptosis of eyelids, miosis, constriction of the pupil, and anhidrosis in ophthalmos, loss of cilio-spinal reflexes. Remember this. The vasomotor changes, trophic changes. I will make you understand here. The clinical presentation of Klumpke's paralysis. See the paralysis of these flexors of wrists and fingers. These are extrinsic muscles like C6, C7, C8, root involved. Flexor carpi ulnaris, FCU. Flexor digitorum profundus, half ulnar, FDP. Palmaris longus, flexor carpi radialis, flexor digitorum superficialis, flexor pollicis longus. These muscles will get paralyzed. And all intrinsic muscles, that is innervated by C8 and T1 roots. So thenar, hypothenar, interosseous lumbricals, all intrinsic muscles and extrinsic muscles. These extrinsic muscles and all intrinsic muscles will get paralyzed, leading to claw hand. See, loss of sensations along the medial border of the forearm and hand, T1. That is cutaneous anesthesia and analgesia. See, claw hand. Claw hand appearance resulting from median and ulnar nerve injury. This claw hand can also be seen in median and ulnar nerve injuries. Note metacarpophalangeal joint hyperextension, metacarpophalangeal phalanx, metacarpal hyperextension, and interphalangeal flexion. Okay. See, this is the complete claw hand. So next is the axillary nerve damage. It can be due to inferior dislocation of the shoulder joint or damaged by the fractures of surgical neck of the humerus. Where the axillary nerve present, it will get injured. So this is the axillary nerve injury. Before going to this, let me say where is the axillary nerve present. See, these are the nerves of the upper extremities. You can see this is the axillary nerve, right? This one. See, the axillary nerve injury is an uncommon condition which results in weakness of the deltoid muscle and numbness on one side of the shoulder. Just remember this itself. Axillary nerve palsy. Atrophy of the left deltoid muscle, like atrophy of the deltoid muscle. Patient lacks deltoid muscle contraction when attempting to raise the arm. See, frequent signs and symptoms: numbness, tingling, burning on the side of the shoulder, weakness of the shoulder, difficulty raising the arm, atrophy, muscle wasting. Etiology: the stretching of axillary nerve from the shoulder dislocation of the fracture dislocation. Direct impact to the axillary nerve from the direct blow to the shoulder can also lead to palsy of the axillary nerve. See, this is the axillary nerve. It's damaged, causing shoulder weakness. See, axillary nerve. This is the danger zone. If you inject needle at this site, danger zone, there might be a dam. You can pierce the axillary nerve, which can cause paralysis of the deltoid. See, this is a danger zone where you should not inject any needle of the syringe.